in terms of us providing nurses. Well, look, they've, I mean, I think our view was we did that at the outset because we kind of got caught. But, you know, there's a whole, all these hospitals have the ability to be able to bring in, I mean, it's expensive because there's a huge demand for it. But that's something that a lot of them have planned for and have been able to do. We don't have necessarily people like that are on the state payroll for that. What we did initially was just have the same type of contracts that a lot of the hospital systems have now.
Governor, we confirmed that the FDA sent you a letter extending the shelf life of 1 million COVID tests. Wondering what will be done with them. We talked to One Cape Coral Medical Center who would really use those tests.
So I think it's important on the old Abbott test, because this has been, I think, reported in ways that are inaccurate. The federal government promised all these tests, right? They said at-home tests, all this other stuff. Well, nothing was happening. And so we had a situation, there's a huge demand for testing. We also, though, in Florida said, you know, people don't need to be running to the emergency room who are healthy to try to get a test. We really want to focus on people who are higher risk. And so we were able, it wasn't easy, we were able to procure a lot of those at-home tests. And those have, so long-term care, we focused that. So those have gone out to there. That has nothing to do with those Abbott tests. Those at-home tests, we got off the market. Again, it's not easy to get because there's a huge demand for this. But we felt that because the feds had said they were going to do it and they didn't, that we needed to come fill that void. The Abbott tests were tests from, you know, a while ago. And they basically, the Department of Emergency Management sources upon request. At the end of the summer, they had expired. The FDA agreed to extend it for 3 months, but those 3 months were almost zero demand in Florida for testing because we had such low COVID prevalence. Then when we got into, so then the most recent expiration was December. You started to see more of a demand for tests. The Division of Emergency Management had been asking about the extension for a long time, got no answer. Finally got some answer for it, and so now those are available. So those are going to be sourced just like they would have been had they been authorized. And so different testing centers, different county health, people that want them, going to go. But those are not at-home tests. Those are older Abbott tests. They do not, you can't just send into people's home. It's literally a box with like 40 tests in it and just one little tube of the solution that you have to put in there. And so they really need to be done by, you know, in a test center, or they need to be done at a county health department or something like that. So those are all going out. But I think the department basically was correct to not send if they may not have been accurate. And so they needed the FDA to be able to say that. You know, it took the FDA a long time, but it takes them a long time to do everything, unfortunately. But those are not at-home tests. The at-home tests that we were able to procure are new. Look, I think there's questions about how accurate some of these instant tests are with Omicron. I don't know definitively. I can't tell you. People have raised questions about whether, you know, what the specificity is compared to how it was previously. But nevertheless, those are out to those high-risk areas. And then the older ones, which are not at-home tests, will be sourced. Okay.
Is there any guarantee that those tests that you're mentioning, the ones that the extension was put on, is there any guarantee that those are all going to be used by their expiration date in March?
It's all contingent on demand, and so if, you know, there wasn't a lot of them being gone out because people weren't asking for them before. So I can't say that there's a guarantee, but I think that you have a lot higher demand for testing right now. And so my sense is that there's going to be enough requests to at least get a lot of those out the door very, very quickly. But look, at the end of the day, you know, they bought too many. They did have a surplus for a while. And I think that's probably better than to not. But at this point, we have a lot of promises that were made by the federal government on these tests. And, you know, look, our testing guidelines that the Surgeon General put on, I think, are very sensible. I think that's where everyone will ultimately end up. You know, when we do these things, we'll get criticized. Oh, how can you send kids to school in summer of 2020? Now everyone says that. How could you do monoclonal antibodies? Now everyone wants monoclonal antibodies. When we came out and said with the testing, when you have something like Omicron, you know, forcing healthy people to do it, to be able to get on a plane or anything like that, that's not the way we've really handled these viruses before, and it's not like it's not been effective in this. So we say focus on symptoms and focus on people that are high risk. I think if you do that, you're going to then be able to have very easy access. I think that's where they'll ultimately end up, because I think what they're doing now is just, it's not sustainable to be doing this. I mean, you'll have places, you know, where people are flooding EDs that have very minor symptoms and are very low risk trying to get COVID tests across the country, and that's not, I think, the proper thing that we want to be advocating for. So that's what we focused on. So that's why we sent it to elderly folks, and we really want to make sure the elderly are able to get it. And we will look to see about these at-home tests in the meantime with the feds not coming up. But, you know, they have promised all this stuff, and then they are imposing testing mandates on different activities. The OSHA case, we'll see. The Supreme Court hasn't ruled on that stay. I think that they're going to say that it's problematic. But if they don't, you know, they're going to be forcing a lot of businesses to be doing these tests on people that have no symptoms. They're forcing travelers to do a lot of these tests, you know, even if they don't have symptoms. And so you wonder, is that the best use of those resources, given the fact that they haven't been able to produce all the other tests that they would? I would say one thing that is another clear, I think, deficiency was not ramping up more production of treatments for COVID, and particularly monoclonal antibody treatments. We showed in Florida, you know, it's very effective. People say, well, we're not sure how effective it is against Omicron, and it's true. There's not definitive trials saying either way. We've had anecdotal evidence. It's helped people get their symptoms resolved with Omicron. So don't you want that to be an option? What about some of the prophylactic ones that are now on the market? That should really be something that they ramp up attention to. And I know in Florida, you know, HHS will always, when we complain about, you know, getting shortchanged, say, oh, well, you guys are using more than other states. But one of the reasons we are is because we've actually provided information and set up infrastructure to help people access this. I was just yesterday, I had a fella come up to me and thank me for monoclonal antibodies. And I was like, well, where did you go to get it? And he said, another state. I was like, well, why are you thanking me for that? He's like, because when you started doing those press conferences, I didn't know that there was a treatment for COVID. So then I got, this guy's telling me he got COVID. He starts calling around to doctors in his state. They all said there's no treatment available. He kept calling, finally found someone and said, oh, yeah, you can do monoclonal. And he got it, and he was going on a bad road, and then he ended up getting better. So those are just things that, you know, we know that needs to be part of it, especially even though, look, Omicron is much milder. I mean, I think that's really good news. If you look at the clinical profile of what we've seen with Omicron, really good news. More contagious, but definitely less disease burden. So that's great. But you still have vulnerable people who may need some of this treatment. So we think it's important to be able to do that, and ramping that up and really making that a priority would have been wise once we saw that this was something that the Sun Belt states were using, because, you know, they made it sound like that wave was like somehow because, you know, these are the wrong policies. Well, now you see huge wave in the north, and that's seasonal. And we knew that was going to happen, so they had the opportunity to prepare for it. I'm not sure that they did, but now to be able to do that and have that, we don't know what will happen in the spring or next summer. That's a no-brainer as far as I'm concerned. And I've said we will do some of this on our own if these companies would be able to deal directly with the state of Florida. They all have exclusive deals with the feds, and I understand that, but we would like to be able to do that if we could. Yes?
Governor DeSantis, a bill was filed yesterday that would ban abortion after 15 weeks. Do you support that bill, and would you sign it?
I have not seen that particular one, but I obviously I'm supportive of 15 weeks. I mean, I think that's very reasonable, and I think that's very consistent with with being supportive of protecting life. So we'll work with them as they kind of get through that process. But I think that that'll be something that we will be able to sign, and I think a lot of people will be very happy with that. Okay, we'll see you guys.
Thank you so much.
Thank you.